This is a major study that was published 4 years ago that got tremendous publicity around the globe. Wen and colleagues, a large study with long-term follow-up of over 400,000 people from Taiwan. And this study got a lot of publicity really because of the dosing. The dosing was stuff about 5 minutes of exercise is all one needs to get mortality benefit, or 10 or 15, you got a little bit more. But there was many other aspects of this study, and I'll come back to this study later. But really, when you look at people with high and low physical activity, the lines start really diverging at around age 60. There wasn't much difference in survival in younger people, but as you get into older age groups, there's a tremendous difference in survival between those who are more highly physically active and those with low physical activity. There's also been a ton of studies that have demonstrated that higher levels of fitness, and we typically define fitness by something called estimated METs, or metabolic equivalents, and it's obtained from algorithms based on speed and incline on a treadmill. But numerous studies show that as you increase the METs from low levels to high levels, you tremendously reduce mortality. And some studies actually even suggested that once you get above about 10 METs, you don't get additional benefit, although certainly a number of studies show small but additional incremental benefits even as you go up to the 15 METs and more. A major meta-analysis was published in JAMA in 2009 by Kodama. 33 studies, had 100,000 patients with a large number of deaths for some good statistical quality, that showed that low fitness increased mortality about 1.7-fold and cardiovascular events about 1.6-fold for basically every 1 MET change in exercise capacity or cardiorespiratory fitness. Mortality and cardiovascular disease events were affected by 13% and 15% respectively. So tremendous effects that fitness has to predict survival. And as Cicero said centuries ago, exercise and temperance can preserve something about strength in old age. Socrates said, "And is not bodily habit spoiled, but rest and illness preserved for a long time by motion and exercise." The Earl of Derby said, "Those who think they have not time for bodily exercise will sooner or later have to find time for illness." And the famous clinician, Paul Dudley White, said, "Healthy exercise is valuable not only for the maintenance of good physiologic functions of the body, but also mental clarity and feelings of good health." But despite all of this evidence, the lay public and clinicians often heed the warning before beginning an exercise program. One should see their doctor. It seems like really one should see their doctor before beginning a program of sedentary living and isolation from the natural world. It's much more appropriate than having someone start a walking program. Question is, how does exercise, physical activity, and increased fitness protect overweight, obese, diabetics, and many people with chronic diseases from cardiovascular disease, and how does it extend survival? And the mechanisms are numerous. I'm not going to go over all of these mechanisms today, but involve improving the autonomic nervous system, reducing blood pressure, improving endothelial function, reducing platelet aggregation and blood clotting, improving blood viscosity. Certainly tremendous evidence that exercise reduces systemic inflammation. But a fact that I think that has been neglected in a large amount of medicine, and this is probably true in cardiovascular diseases as well, is the role that exercise has on mood and psychological function. And there's tremendous evidence that psychosocial stress is a tremendous trigger of cardiovascular disease pathogenesis and plays a role in the recovery of patients following cardiovascular disease. And as Cicero also stated, it is exercise alone that supports the spirit and keeps the mind in vigor. We published this paper a decade ago in our coronary population at Ochsner in New Orleans, showing that if our patients who have had major cardiovascular events like heart attack, bypass surgery, needing percutaneous intervention because of acute coronary syndromes, that our patients have a tremendously high prevalence of psychological stress as determined by validated questionnaires. Almost a quarter meet criteria for depression, a little bit higher in the older versus the younger. We defined older as above age 70 and younger as under age 55 for this study. Tremendous high prevalence of anxiety in the younger patients, less so in the older, but still quite high. And hostility, which is another way to express unexpressed anger, was also considerably higher in the younger compared to the older patients. But following a formal cardiac rehabilitation and exercise training program, this program is a 12-week program, 3 times education and exercise programs per week for 36 education and exercise sessions, and our patients are encouraged to exercise 2 to 3 times per week outside of the program. Following the completion of phase 2 cardiac rehabilitation, there were dramatic reductions in the prevalence of anxiety, more so in the younger patients who had such a high prevalence to begin with, but also quite nice reductions by 40% in our older coronary patients. Again, hostility also fell by over 50% in prevalence following the cardiac rehabilitation and exercise training program, with equal improvements in the younger and the older patients. Now, there's a lot more in the literature about the effects of depression on the pathogenesis of cardiovascular disease and many chronic diseases. And following cardiac rehabilitation, we saw almost an 80% reduction in the prevalence of depression in the younger patients and about 70% reductions in the older patients, again, following formal cardiac rehabilitation and exercise training. But one of the reasons that this is so important to us in cardiovascular diseases is that our patients who are depressed following cardiovascular events have a mortality during the next 3 years that's over 5 times higher than those who did not meet the criteria for depression and otherwise had similar characteristics. The controlled depressed, this might not be a fair way to say it because we considered the controlled depressed the patients who met criteria for depression but who didn't attend a cardiac rehabilitation and exercise training program. So one could certainly say that those are not exactly the same as the patients who were depressed but decided to attend the cardiac rehabilitation program. But this is about the best we can do for a control today because cardiac rehabilitation is considered a quality metric and is a standard of care, although very few percentage of patients actually attend cardiac rehabilitation. But those who were depressed following a cardiac event but attended and completed a cardiac rehabilitation program had a greater than 70% reduction in their 3-year mortality compared to the patients who were depressed who did not attend cardiac rehabilitation. Now, cardiac rehabilitation is more than just exercise. Exercise is the primary component, aerobic exercise and resistance training, but there are other aspects of cardiac rehabilitation. There's group therapy, so in some ways having group sessions the way psychologists and psychiatrists do. There's a lot of tender loving care administered by our exercise physiologists and nurses and dietitians. So we tried to determine how much was the benefit coming from the exercise and particularly the improvements in fitness. And we actually measured fitness. Most of the way fitness is measured across the world is by estimating the METs based on the speed and incline of the treadmill. But we actually measured the fitness with cardiopulmonary stress testing, with gas exchange, which is considered the gold standard to assess fitness. And we showed in this paper, in the American Journal of Medicine almost a decade ago, that those who did not improve their fitness, who had a peak VO2 following the program that was the same or less than they did at baseline, and we have another paper coming out right now showing that about 23% of patients in our cardiac rehabilitation programs do not improve their fitness despite attending all of the exercise training sessions, and there's things different about those patients. But those who did not improve their fitness continued to have high prevalence of depression and high mortality during the next 3 years. Whereas those who got a little bit improvement in their peak VO2, we defined a little bit as between 0 and 10%. Now, if we estimate METs, the improvement is much higher than that, but if you actually measure the improvement with peak VO2, the typical improvement, the average is about 13 to 15% improvement in peak VO2. But those who got just a little bit improvement, 0 to 10%, or a whole lot of improvement, greater than 10%, both had pretty similar reductions in the prevalence of depression and low mortality during follow-up, suggesting that one only needs to get a little bit improvement in the fitness level in order to maximize the reduction in depression and depression-related increased mortality rates. In another study, also in coronary disease patients, but we choose 150 patients who had evidence of heart failure, we showed that the prevalence of depression is even higher in the heart failure patients compared to others, and they get substantial improvement in their reduction in their prevalence of depression following cardiac rehabilitation and exercise training, about a 40% reduction in the prevalence of depression. But the heart failure patients, who have a higher mortality to begin with than other types of patients, had an extremely high 43% 3-year mortality when they met criteria for depression, whereas those who were non-depressed had only a 10% mortality during the next 3 years. Otherwise, they were statistically similar. Once again, we showed in this heart failure population that those who did not improve their fitness, did not improve their peak oxygen consumption, continued to have a high prevalence of depression and a very high mortality rate, whereas those who improved their fitness, but just small improvements, had significant reductions in depression and had mortality that was almost a third that of those who did not improve their fitness. So it's not just about fitness that we're concerned about, but we particularly are concerned about low fitness. Those people in our society that fall in the bottom quintile, the bottom tertile of fitness. Sure, if they can improve their fitness dramatically, get themselves up into the highest quintile, maybe even the highest 5%, they might get continued reductions in their relative risk of cardiovascular disease and mortality. But by far the biggest bang for the buck is to get people out of this low level of fitness and move them into the next quintile or maybe a little bit higher. The biggest bang for the buck is the initial benefits of improving cardiorespiratory fitness out of the very low categories. Now back to that WIN paper that I started to talk with, the Lancet paper, 2011, that over 400,000 Taiwanese, that showed the differences in physical activity at above age 60 producing survival benefits. But they also, and what got all the publicity in this trial was that only 5 minutes of exercise produced significant mortality benefits and only 15 minutes had quite significant mortality reductions. People like to hear that you didn't have to do a lot to get mortality reduction. But if you look at the dosing, at a moderate level of physical activity, it looks like the more you did, the more benefits you achieved, with the line starting to level off after about an hour. But at vigorous physical activity, and these authors defined vigorous physical activity at only a level of about 6 to 7 METs. Most of us, 6 to 7 METs is about a fast walk or a very slow jog. Most of us would not consider that to be a very high or vigorous physical activity. It certainly would not be similar to out running at a pretty good clip, which would be 10 METs or higher. But in this paper where they defined vigorous physical activity as 6 to 7 METs, they showed that the line starts leveling off even after about 30 minutes. And even though they don't have a lot of statistical power, out at long quantities, there did not appear to be any obvious additional benefits with more significant vigorous physical activity. And again, defining it as only 6 to 7 METs. Well, this brings a big paper that we published in JACC, which is our leading Journal of American College of Cardiology, our leading clinical cardiology journal a couple of years ago. It also received a lot of publicity from the press. We assessed 55,000 people, 13,000 runners and 42,000 non-runners, with an average follow-up of 13 and a half years for cardiovascular disease and all-cause mortality. In this paper, we showed that the runners had significant reductions in mortality by 30% and cardiovascular mortality by 45% compared with the non-runners. An average life extension of 3.1 years, an average cardiovascular life extension of 4.5 years among the runners. Now, this, I'm not sure, was a significant surprise, because many people would think that running would be associated with better health. The fact that someone can run would mean that they were healthier. And the running itself might be providing some health benefits. So this wasn't a substantial surprise. Also, when we looked at persistent runners, they had the full benefit. And those who started running but stopped, but those who weren't running but started, had about half the benefit as did the persistent runners. I'm just actually noticing that on the transfer, all of the titles were erased. I didn't notice that one, but anyway, I don't think we lost anything. And we showed here that the more you ran, the fitter you were. And typically, higher fitness is associated with better mortality reduction. Although you could say that even the low runners, the runners running less than 30 minutes per week, were already pretty fit with average METs of 12.5 on fitness tests. What we were surprised at, though, was that we divided our 13,000 runners into dosing, to quintiles of doses. Things like minutes per week, miles per week, times per week, speeds that they reported running. And when we did that, we showed that quintile 1, which was the lowest level runners, these were people who were running less than 6 miles per week, running only 1 to 2 times per week, running less than 52 minutes per week, had the same benefits on mortality and cardiovascular mortality as those in quintiles 2, 3, and 4, and slightly, trend, not statistically different, better than those in quintile 5. In a paper in Mayo Clinic Proceedings 2 weeks ago, we divided quintile 5 into tertile. So we looked at the highest tertile, which is the top 7% of dosing, and we showed that this group lost the benefit from running on cardiovascular and all-cause mortality. Not compared, not significantly different than non-runners, but no better than non-runners, but significantly different than low-dose runners. Now, typically in cardiac rehabilitation, we show that the benefits are related to higher fitness. No matter how you assess fitness, by estimating the METs, peak oxygen consumption, gas exchange, or the 6-minute walk test that is done often clinically, those are usually the things that predict survival. But in an editorial for a paper that was published 2 years ago, we talked about that there are differences between the health benefits and the benefits regarding peak performance. And this was an editorial for a paper by Paul Williams and Paul Thompson. Paul Thompson's probably one of the most famous in the world in the area of exercise training in athletes. and particularly athletes with cardiovascular disease. This is a paper that they assessed 2,400 myocardial infarction survivors, people who had survived heart attacks, who were followed for over 10 years for mortality and cardiovascular disease mortality. And they showed in this paper that those who exercised more met hours per day, continued to get benefits with reductions in mortality and cardiovascular mortality, up to a point, up to about 7.2 met hours per day, which is the equivalent of about 30 miles of running and 45 miles of walking. The MI survivors appeared to lose the benefit. Again, not worse than the non-exercises, but considerable loss of benefit compared with the lower exercises. Now, we have also focused on some of the potential adverse effects of extreme exercise. And I'll just give you an example, because there's not enough time to go into all the details with this. But for example, if you study people after a marathon, and there have been many papers that have done this and had similar results, about a third of marathon finishers release cardiac troponin. That's the protein that we test for in the emergency room to diagnose myocardial infarction. About a third release high amounts of BNP, brain natriuretic peptide, or atrial natriuretic peptide. That's the protein we test for to help diagnose heart failure and assess heart failure severity. And if we do scans of the heart, like echocardiograms, we notice that there's dilation of the heart in about a third, particularly of the right side of the heart in the right atrium, and dysfunction of the ventricular septum and the right ventricle, that fortunately returns to normal days and a week or so following the event. But certainly there's evidence of immediate toxicity. And there's a lot of people doing some of these long races now. And even though the sudden death rate is relatively low, there are a number of events that report sudden cardiac death. And if any of you have never worked the medical tents of some of these high events, I can tell you that you see a lot of sick people after doing these extreme events, and occasionally some of them die. Most of them don't. Most of them are feeling pretty good about their performance the next day and a week or so later. But in one Detroit marathon, I got this slide from Barry Franklin, within 30 minutes, 3 people died. And this produces concern about the toxicity of very high exercise. And as Hippocrates said centuries ago about moderation, if we could give every individual the right amount of nourishment and exercise, not too little, but also not too much, we would have found the safest way to health. Now, clearly, people who are doing high amounts of exercise are not doing it for health. It appears that you get the maximum benefits at much lower doses. Of course, the reason why people are doing high amounts of exercise is because of sports, competition, camaraderie, ego, fun, but it's not for health, because the maximum health benefits occur very early. In our efforts on exercise as medicine, we really believe that we need to have, though, exercise as a vital sign, along with heart rate, blood pressure, pulse, weight, BMI. We need to have information about the exercise, and if the exercise levels are low, we need to have prescriptions for exercise in the medical record. And we discussed this in an editorial and commentary in the Mayo Clinic proceedings a couple of years ago that received a lot of attention, physical activity promotion throughout our healthcare system. So in summary, we have 2008 federal activity guidelines that suggest that all individuals should be doing about 150 minutes per week of moderate physical activity, or 75 minutes per week of vigorous physical activity. The Institute of Medicine actually recommends about 60 minutes per day of all physical activity. This would include walking from your car, going up the stairs. Recent evidence, though, suggests that the benefits of exercise occur even at levels well below this. And with running, for example, maximum benefits appear to occur at very low levels. In coronary disease, toxicity may occur at high levels. And in almost everyone, the maximal benefits, at least from health standpoint, appear to occur within 40 minutes and probably certainly less than 60 minutes. Promotion of physical activity and exercise training, though, is needed throughout the healthcare system, which can start with exercise and our fitness as a vital sign. And we hear this all the time as clinicians: give it to me straight, doc. How long do I have to completely ignore your advice? Most people, the reason why they give that they can't exercise, they don't have enough time. I used to have 30 minutes, 60 minutes on here. Later I put it 30 minutes. I took the time out now, so I'm not sure what the time is. But the answer still is what fits your busiest schedule better: exercising for so many minutes per day or being dead 24 hours a day. Thank you. Yes, ma'am.
So what do you think the cause is with peak runners where the benefit plateaus and then goes down?
You know, it's hard. First of all, it appears that there's many things that there's a dose response curve. You know, there's many medicines that by raising the dose you don't get additional benefit.
But
and
the endorphins though, which keep you going.
Yeah. But so what I'm not positive of is that, okay, we're showing that at least very high amounts is associated with loss of benefit, or particularly not additional benefit. People will argue that the cell size that we recently showed, the loss of benefit, was only 7% of runners, and the number, you know, gets down to less than 1,000 people and pretty low mortality. And so our statistical power, could be questioned. But certainly the evidence is very strong that more is not better. And we even think that it raises the idea that more could be worse. Now, but is it actually worse, or is it just associated with worse? We can't tell from our data that the people are losing the benefit because of running more. So if they would have stopped at 30 miles, but instead they keep going up to 35 miles per week, is that extra 5 miles causing them to lose the benefit? Or is there something else about those people? Psychological stress, addictive personality, type A, things that could be making those people different. Because obviously you can't do randomized studies. You wouldn't be able to do a randomized study of exercise versus no exercise for 15-year follow-up, much less giving people doses of running. So this is probably about the best we're going to be able to do to get answers like this. Yes.
In some neuromuscular diseases, whether it's ALS, neuromuscular dystrophy, or muscle, people have argued that exercise is bad. Do you have a sense of that? Is that right? Or is there evidence lacking?
I don't think that, I mean, again, I don't think there's too much evidence that exercise is bad. Claude Bouchard had a paper in PLOS One that got a publicity a couple of years ago that suggested that there are adverse responders to exercise, that people actually got worse several things in their metabolic profiles following an exercise training program. I really don't think there's a lot of evidence. Even I mentioned that in our cardiac rehab program, 23% don't improve their exercise capacity. But they still get benefits in some other aspects, although they still don't get nearly, those who don't improve their exercise capacity don't get nearly the survival benefit as do the other patients. There certainly could be patients who exercise too much and actually hurt their muscle. Because there's a lot of evidence that muscular strength is a very important predictor of our cardiovascular risk factors and a very important predictor of cardiovascular survival. Certainly people who, in our cardiac practices, the patients who have more muscle do better than those who are thin and frail and cachectic. But there could be a point where very high doses of exercise could actually be hurting muscular fatigue and hurting muscular strength. Yes. Yes.
Well, from a dose response standpoint, is there data about, say, exercise intensity, doing sprints, that kind of thing, as opposed to all the duration?
Yeah. Yeah. I think most exercise specialists believe that high-intensity interval training is preferable to long, chronic pace training. But almost all of that data is based on improving fitness and on small studies looking at cardiac structure and function. So all of those studies typically show that high-intensity interval training is better. And of course, that's how an athlete's going to train. If somebody's going to try to run a mile race, they're not going to just go out and run a mile. They're going to have to run, some fast quarters. And people who run marathons run some fast miles, to train for running, with high intensity. The problem is, though, there's no data with regards to clinical events and survival. It's all based on surrogate endpoints. I personally believe if we could ever do that kind of study, that the findings would be in favor of high-intensity interval training. Why would it, if it improves fitness and cardiac structure and function, why would it not have a benefit over regular low-intensity exercise on survival? But there's no data to support that. And just as an example, in heart failure, myself and 3 colleagues did a meta-analysis a couple of years ago on high-intensity interval training versus lower intensity in heart failure. And the total number of patients that we had in our paper was 113. So nothing even close to giving survival type of data. Yes, sir. I mean, I think it can. There certainly is data, not as plentiful as our running data, and there's also been a big Copenhagen running study and a national running aging study that showed data with running and mortality. But there is certainly data that skiers and cyclists also have good longevity. I don't think the data is robust as our running data, and the relative benefits of different forms of exercise, have not really been shown. Like for example, would a lower impact exercise like biking not be as good or better than running, which is higher impact? I don't think that's really been shown, and the same thing with swimming and skiing and stuff like that.
What about the animal model studies where you have a dose response study with different nets? You could go from very minor to very extreme. Any research on that?
Well, I mean, there certainly has been papers in animal models that high levels. A really good paper just about 3 to 5 years ago by Benito, B-E-N-I-T-O, in Circulation, had rats do 12 weeks of hard running daily and showed that the hard running in rats led to thickening of the walls, dilation of this chamber, and a percentage getting fibrosis in their muscle. And then about 43% of the high exercise rats ended up getting inducible ventricular arrhythmias compared to only about 7% of the non-exercising rats. And this all reversed during a period of detraining. So certainly exercise is good. And there certainly is data in animal models that show many things that improve with exercise training. But at high levels of exercise, there are certainly animal models that show a toxicity model.